All right. Well, thank you everyone for joining us for our latest media briefing on important healthcare issues in the news. My name is Dr. Adam Kassam. I'm a physiatrist in Toronto, where my clinical practice is focused on musculoskeletal and neurological rehabilitation of patients, including patients that I now see in our rehab hospital. I'm also the newly installed president of the OMA, and I'm pleased to be moderating my first OMA media briefing as part of my new role. As you know, we represent more than 43,000 doctors and medical students across the province. COVID-19 cases in Ontario are finally falling, but 3 significant waves of infection have created a lengthy backlog of surgeries, diagnostic exams, and other healthcare procedures. We know that the backlog will continue to grow and that many conditions are going undiagnosed or underdiagnosed. Many people have not yet seen their doctors during this pandemic and may have conditions we actually don't yet know about. Preventative screenings for serious conditions such as breast, colon, and skin cancer have fallen off. Some chronic conditions such as diabetes and high blood pressure have grown more serious as non-COVID-19 patients waited longer for treatment. So that's why we're here today, to talk about tackling the pandemic backlog. Just how extensive is it? Do we fully know that answer? What kinds of treatments can we say with certainty have fallen behind? And have cancers gone undetected? Have patients grown sicker as they waited for treatments? Will the effects of the pandemic be felt for years? And what are the solutions to wrestling the pandemic backlog? What will it take to address? Is there a framework that we can actually implement, and who is thinking about these kinds of solutions? We'll hear from a family physician, a dermatologist, and a cardiologist. I'm really excited because these are experts who can speak to the effects of the pandemic on non-COVID patients, the healthcare system itself, and how it needs to respond as the recovery phase itself begins. I'll introduce our guests by name shortly, but I'd first like to walk you through some of our own OMA data on the pandemic backlog. So the OMA actually compared OHIP billings from 2020 to 2021, and over that period of time, we found an estimated backlog of 15.9 million healthcare services that were delayed. And if you do the math, that's 1 per person in the province of Ontario. When we looked at the data more specifically, we found that the estimated backlog was greatest for MRIs, followed by CT scans, cataract surgery, knee and hip replacements, and coronary artery bypass grafts. You can find all this specific backlog data for each procedure and diagnostic test that I've mentioned in our news release and on our website. The backlog really is considerably higher in community settings than it is in hospitals. This tells us that while Ontarians have been actively getting their COVID vaccinations, which is great, they have been deferring visits with their family doctors where they would normally have things like mammograms, pap tests, colon cancer screening, and so on as part of our comprehensive approach to preventative medicine. Let's not forget that the doctor's office is also where chronic conditions such as diabetes and high blood pressure would be identified and managed. The OMA has estimated how much time clearing the backlog might take, which I think is a relevant thing to be thinking about moving forward. And let's be honest, the numbers that we've found are startling. 22 months for knee replacements, 21 months for cataract surgeries, 14 months for hip replacements, and 10 months for coronary artery bypasses. Again, those details are all in the news release and available on our website. But what I want to stress is that those estimates would require physicians to work at 120% capacity, which really isn't feasible. The backlog itself also doesn't just implicate proceduralists and surgeons. Clearing the backlog will also put pressures on other parts of our healthcare system. The family docs who are providing preventative care, physiatrists like myself who see and take care of patients after surgery, or doctors caring for residents in long-term care. The pandemic backlog isn't just confined to the operating room, and that's a very, very important point. It's also important to note that the pandemic backlog is in addition to the wait lists for procedures that have existed before the pandemic began. And so the OMA is developing recommendations on how to address this backlog as the healthcare system enters the pandemic recovery phase. It's a complex problem with lots to think about, and it will require a cross-functional team response involving many partners across the healthcare system. So to inform those recommendations, we're actually gathering information here today. And the OMA is engaged in a broad-based listening tour, asking our members, our healthcare partners in hospitals, government, and in the community what the future of healthcare in Ontario should be and what it should look like. Doctors in every region of the province have been meeting to discuss what changes are required to emerge stronger from this pandemic. And that is, I think, what we all want to have happen. And through our survey, which you can find at betterhealthcare.ca, we are asking people and the people of Ontario to help us make recommendations that will address immediate healthcare priorities, as well as long-term care, the pandemic backlog, access to mental health, and other issues that haven't yet had the attention that they deserve. So I encourage everyone to speak up, have your say, help us shape the future of healthcare. With all of that being said, I'd like to now introduce our three esteemed guests. Each of these doctors is on the front lines and can speak firsthand about the pandemic backlog and how we might tackle it. First up is Dr. Sohal Goyal, who is a family physician in Mississauga, where he leads a family health group of more than 140 physicians. He's an assistant clinical professor in McMaster's University's Department of Family Medicine. He is chair of the Mississauga-Halton Primary Care Network and chair of District 5 of the OMA. Dr. Sandra Landolt is a dermatologist in Thornhill and chair of the dermatology section of the OMA. She holds Royal College fellowships in dermatology and internal medicine, and she's actively involved in women's advocacy and mentorship and is the past president of Canadian Women in Medicine. Lastly, Dr. Harinja Wijasindra is the chief of the Shula Heart Program and head of cardiology at Sunnybrook Health Sciences Center. He's an interventional cardiologist and senior scientist at Sunnybrook Research Institute, as well as an adjunct senior scientist at ISIS. He's a professor in the Department of Medicine and the Institute of Health Policy Management and Evaluation at the University of Toronto. So quite an esteemed panel. I'm excited that we were able to get into this conversation right now. Dr. Goyal, will you start by telling us what family physicians like yourself are observing about their patients?
Thank you, Dr. Kassam. As Dr. Kassam mentioned, the data shows a significant drop in doctors' visits. The data states a 12% decrease in visits, but in reality, it is much more. Many of the visits this year include patients with COVID symptoms or questions about COVID or vaccines. When those visits are subtracted, the drop in visits is even more significant. As a family physician, one of my areas of expertise is in disease prevention. We have seen less preventative tests done to screen for illnesses, such as mammograms for breast cancer, tests for colon cancer detection, and Pap tests for cervical cancer. Less cardiac testing has been done to detect heart disease. Less blood work for disease detection like high cholesterol. As we all know, early detection leads to early treatment and prevention of illnesses such as strokes. Less blood work has been done in our chronic patients in terms of progression of diseases like diabetes, which requires regular monitoring and blood work. We are diagnosing patients later, as many are not going for the screening tests or couldn't go due to the pandemic. This will cause even more delays as the burden of illness is greater. Even though visits have significantly dropped, complexity of illness during visits has increased. In my own practice, I have seen an over 400% increase in mental health related visits. The stress caused by the pandemic increased depression and anxiety, affecting relationships and increased burnout. We are seeing the effects on children and teenagers staying home, not interacting with their peers. Even though we're getting through this third wave, the effects of the pandemic will be felt for many years, whether it be in anxiety or post-traumatic stress disorders, or dealing with patients who have long COVID. I am concerned about the backlog of procedures and patients dying on waiting lists or suffering with chronic pain while they await their hip or knee replacement. Family physicians have been working at COVID detection centers, vaccination centers, and have been supporting the system throughout the crisis. We had to focus on those patients most sick, and patients stayed away from our offices due to the burden of COVID. We need to catch up on the preventative care and screening. We need to focus on helping so many suffering with mental illness. I want to stress to patients that your Ontario doctors are open. We're ready to talk to you, to see you, and help you through the crisis. Thank you.
Thank you so much, Dr. Goyal. And I really appreciate that that perspective. And I'm seeing very similar things in my practice with regards to people delaying care, seeing them ultimately have more of the pathology that would have perhaps been averted if they'd been seen earlier. And so I think a lot of those points are very well made and well taken. Dr. Landolt, you bring the perspective of dermatologists to this discussion. What has been the impact of the backlog on melanomas, other skin cancers, and just generally sort of the diagnostic approach during COVID?
It's actually very interesting listening to Dr. Goyal talk about the backlog that we don't even know about yet. It's so much true. It's so much the case in dermatology. When we started out 15 months ago, we had no idea that this would still be going on 15 months later. In our minds, we probably all felt it was like a 3-4 month thing. By the summer, things would be better. We didn't know what we were dealing with. We didn't have PPE. We didn't know what was going on, and we had to pivot very quickly. So what my practice did, and I think most of the dermatologists, was cancel people and then call them and then reschedule a whole new list of visits based on urgency and what we had heard from the patient in terms of the cancellations. So for the first 3 months, we saw patients urgently. Almost every one of those patients had a large skin cancer. So out of the 8 patients I would see in a half day, twice a week, almost everybody had a large skin cancer, and we had to work at finding surgeons and people to remove these skin cancers. And fortunately, our colleagues were working in out of hospital settings because there were no ORs running at that point in time. After July of 2020, the majority of dermatologists were back seeing patients in person, almost, I would say 80% of patients in person, because we'd realized at that point in time how difficult it was to take care of patients virtually because our specialty is a visual specialty. And in that time period, we were seeing less patients, but clearly the patients that we saw that had malignancies had more advanced and obvious skin cancers because there was no screening particularly going on, and patients were also afraid to go in and see their primary care physician. So we can maybe move on to the next slide. So definitely over the past 12 to 15 months, we've seen more obvious and more advanced skin cancers. And this is actually supported in a number of studies in the literature, both in terms of physician surveys, visit surveys, and a very elegant paper that was presented in the Journal of the American Academy of Dermatology in January of this year. This paper examines a group of patients and the pathology specimens between 2019 and 2020. So a fixed cohort of a community was examined in terms of the pathology findings in 2019, and then the same cohort of physicians who were studying in pathology in 2020. And they actually showed in this paper that there were 279 melanomas less and 6,000 squamous cell carcinomas less in their cohort. And if you extrapolate their cohort to the Canadian population of 38 million individuals, that essentially means we've probably got close to 2,000 melanomas that haven't been diagnosed in that year, and 46,000 squamous cell carcinomas also undiagnosed in that year. Now, just for those that don't understand, these are the types of skin cancers that are more serious and potentially can metastasize and lead to a poor outcome. So of not a skin cancer like a basal cell skin cancer, which is something that isn't going to give you a bad outcome, but will be a problem if it's not removed in some timely fashion in terms of extension and disfigurement. So the close to 2,000 melanomas and 46,000 squamous cell carcinomas that we have missed in Canada could possibly lead to severe morbidity and even death. Next slide, please. So a recent survey had similar results, and the Melanoma blog actually put this out, and they've actually got a Hunt for the Melanoma initiative going in terms of trying to encourage people to increase screening visits, because they feel that they can find the 1,999 melanomas that were missed during the COVID pandemic. Thank you.
Thank you, Dr. Landoltz. You know, part of your presentation there was obviously very concerning in terms of how much of that delayed screening and diagnosis early on can actually affect people and patients' outcomes, their morbidity, their mortality, and how treatment will ultimately affect the course of the disease. And I think we're seeing that across the spectrum in healthcare, whether it's in skin cancers or colon cancers or breast cancers, but also just other types of preventative care. So thank you for that. Dr. Wichisindra, we've shared some concerning data and anecdotal evidence here today about some of the emerging considerations about backlog for services and procedures. You're a health systems expert, you do research in this field, you're an active cardiologist doing interventional procedures. What are some of your thoughts on how we might address this?
Thank you, Dr. Kassam. I think as I try to think about potential solutions, I want to frame it not only in the enormity of the backlog, which the statistics that you've presented show, and the comments from my two other speakers, but also its complexity, that it's not simply a larger number of patients on a wait list that need care, but rather it's a care deficit, right from patients identifying the symptoms, feeling comfortable enough to seek treatment, being seen by their family physician, getting diagnostic testing, seeing a specialist, and then finally getting on a wait list if it's a procedure or surgery. And each of those steps have very different obstacles, but they've had obstacles and people have got stuck throughout those over the course of the last year, and they've compounded each other. Anecdotally, when the pandemic started, all of us, as was mentioned, were concerned that our patients are going to be sicker, and we've seen that. Now, unfortunately, over the year, we have data that has confirmed what our clinical experience at the front lines are. And certainly in the cardiac realm and work with Core Health Ontario, just focusing on coronary and valve disease, we know that the patients who've got on the wait list are sicker. In fact, data suggests that since March of last year, twice as many have died on the wait list during that period compared to historical controls. But probably most importantly, the actual wait list is smaller than we anticipate when we calculate what the backlog should be. So those patients are missing. They're missing upstream, and Dr. Landau showed a picture of an iceberg, and I think that's a very apt anecdote that we're seeing the tip of that, and what we're seeing on the tip of the iceberg are patients that are sicker. So given both the complexity of the problem and the enormity of the problem, my perspectives on the solutions are there aren't going to be any quick and easy ones. But the solutions that we have, I think, should follow three principles from my perspective as somebody on the front line, but also in hospital leadership, and I've had a chance to contribute to system planning. And the first is that it's not going to be a sprint. As much as it would be nice to think that we add resources in a bolus, work at 125% of capacity, and then get back to our comfortable status quo, that's not going to happen. And so this is going to require the same intensity of attention, but also length of attention that the COVID response has had from all levels, from the front lines, from government, from system planners, and it will require that type of resource also because it will take a marathon. It will take many months. And what finally emerges from this will likely be a fundamentally different healthcare system. And so as tired and stretched as all of us are, we need to be prepared to be able to shift gears, have wellness at the front of this, that we have enough stamina to continue that path to this new health system that we're going to come to. The second principle I believe is important, that especially in the last wave, we saw that there is immense potential when we think of our healthcare system as a provincial resource. That the load sharing of COVID cases, as difficult as it was to do, the impact of the last wave, had we not done that, would have been catastrophically worse. It did require, however, that there be system leadership as well as will and the front lines. And as we enter into the recovery phase, we need to think of this as a healthcare system, that we're not stuck in our silos, that we think about load sharing or system solutions, but that will require leadership. And finally, I think there's several themes that have emerged from the pandemic, one of which has been inequity, that certainly in the last wave, the populations most affected were marginalized populations, racialized communities. Those most vulnerable were most affected by the acute phase of the pandemic. And if we're not deliberate in our recovery phase, that every solution we have, we force ourselves to look through this with a lens of inequity, then it will be a tragic theme of this pandemic that what we recover to will continue to exacerbate these inequities. So I think those three principles for me must frame the difficult path towards coming to solutions during the recovery phase.
Yeah, thanks, Dr. Wijesindra. I think that there are a lot of very salient points there and kernel and nuggets of gold that you're sort of describing there in terms of how this is really a pipeline, and how when we think about healthcare, we think about prevention, intervention, and then rehabilitation. And this pandemic has shown how we are moving through all three of those phases, and what this sort of marathon and not a sprint is going to require in terms of energy, health, human resources, restructuring, and then hopefully a coordinated effort to really get through all of this backlog or pandemic deficit of care that you're describing. I appreciate all of those points. I wanted to first of all thank Drs. Wijesindra, Landolt, and Goyal for being here today and for providing your perspective. What we're now going to do is we're going to open up our Q&A session. Leslie from Crestview Strategies will actually walk us through the Q&A. So if you do have questions, please put them in the Q&A chat. If we do not get to your questions due to time, the media team will follow up with you, and you can also email media@oma.org with additional requests for interviews or information. And we will have a recording of this session available later this afternoon. So with that, Leslie, I'll turn it over to you.
Sure. Hi, everyone. So we're going to dive right into today's Q&A. So I'm going to start with a question actually for Dr. Kassam, and it is, what is the difference between wait times and the backlog?
So I think that's a very specific question about wait times. Means how long does it take for someone to be diagnosed with a disease that then ultimately needs a treatment? So what is that sort of delta between time from initial assessment to actually being treated? Backlog, I think, as Dr. Wijesindra was describing, describes perhaps a more broad conversation about deficit of care. So, how do we, as we have already described earlier, how do we get people screened for a disease? So hopefully they don't have the disease or can prevent the disease. That's one aspect of sort of this pandemic deficit. It includes screening, but then also non-procedural interventions. So whether it's blood pressure or diabetes management, or even on the rehab side. So for example, how do we, in my line of work, how do we get a person a brace after they've had a foot drop or had a leg injury? And so sort of a comprehensive approach to care delivery is the difference between sort of wait times themselves and backlog for all of these different pillars of healthcare that we have in our system.
Absolutely. And I have a bit of a follow-up to that question. I might direct it to Dr. Wijesindra. How long will we continue to see the longer-term impacts of this backlog?
So I think that's a my answer is going to be necessarily a bit complex to that, because I think the question has a lot of layers. So the patients who are most sick that have been waiting, we're going to continue for a while to see that the patients that we're treating, we're diagnosing and starting our treatment later in their time course. And I suspect that will continue for a while. I think the flip side of that, however, is we calculate the backlog as simply the difference in historically what we expected to see and what we actually saw, because there's no reason to think that during the pandemic the incidence of disease has changed, and that's true. Certainly, that's true for cancers. In certain conditions like mine, in cardiac disease, there is no reason to doubt that the incidence of heart disease has changed. So we would expect those patients to still have problems, but there's not a kind of binary approach to treatment that you must treat with X or Y. There's usually a scale of things that we do. And I think the longer term consequences of having this care deficit, having limitations on resources for procedures, is that we will likely change what is the first option we use versus the second option and the third option. And that's not to mean the second and third option are bad options. Just when we didn't have to make those choices, we made them in a particular way, and we may alter that. And that's why I believe that what finally comes out of this will fundamentally be very different. That doesn't necessarily mean it will fundamentally worse. I think it's an opportunity to rethink some of the ways that we've done things and think if newer ways, given the resource limitations that we have, the reality of the backlog will be better. And I think if framed in that line, this is an enormous problem, but also an opportunity for change.
I wonder, Dr. Goyal or Dr. Landau, do you have anything to add from your own experience and your own practices?
Yeah, the difficult part about this is actually, as Dr. Landolt, rightly put in her slide in terms of that iceberg, and we're starting to see some of that come out now in our family practices, at some of the urgent care centers, at the emergency rooms, where patients are coming in, and they're coming in for one reason. And as you speak to them, they're coming in for their sore arm, and you speak to them and you realize that, due to the pandemic, they're experiencing things like anxiety or depression. And they didn't know where to turn to, who to ask for advice. And you're seeing multiple comorbidities when they present, where previously they may have come in for one reason. Early on, when they're symptomatic, it's kind of that increased basket that they're coming in with, and thus the complexity has increased. So we're definitely seeing that in our family doctors' offices for sure.
We're also having to, or have used, treatments that may not have been our treatment of choice because we had no choice but to adopt these treatments. I mean, examples would be when the retirement homes and long-term care were locked down. And so we would be seeing patients by photograph and telephone who had skin cancers, but they were locked in, like they were locked down. So we would be using various other methods which would maybe not necessarily as commonly used, to try and get things at least better or under control, or reduce spread or burden over the course of what ended up being actually many months. So yeah, it's really changed. It's expanded the way we treat people, and ultimately some of these changes may be permanent, and that's okay.
Thank you for your answers, everyone. So the next question I have is from Sneh Dougal at Queen's Park Briefing. And their question is, as part of the province's plan to address the surgical and procedural backlog, the government noted in its fall plan and budget that part of its investment will be used to create a centralized provincial surgical waitlist program. What are your thoughts about this idea? And kind of as a follow-up to that, what will it take to implement it? Has it already started on the ground? And I perhaps will direct that to Dr. Kassam to kick us off.
Yeah, sure. So, the question is a good one because it really speaks to how do we, in a future state of our healthcare system, allow for quicker referrals to happen in a more timely way so that ultimately patients can get the care that they need at the right time, and ultimately have the best outcome. And so I think when we're thinking about this issue, we need a systems lens when we think about referrals from primary care or specialists to proceduralists or to other specialists for care. Has that happened in the most efficient way? Probably not so far. And I think patients across the province would tell you, and even providers would say that there is a better way to do it. I think the challenge is, how do we operationalize this particular phenomenon? There are other jurisdictions across the country that have attempted to do this, Alberta being one, namely sort of noteworthy example. And so is there room for some of that movement? I think that there is. I think it depends on how the integration between all of our health system partners. So Ontario Health is starting to build out their strategy for a future healthcare system. How does that play into a centralized referral system for the province and for patients? I think it's a good question, and it will require us to work along, across lines and across health system partnerships to really nail down. But maybe Dr. Wujasindra could actually provide some more depth on that because of his experience in this realm.
Sure, thank you, Dr. Kassam. I think the key term there is program, and the actual manner in which it becomes operationalized, I think, will depend on local circumstance, the type of condition. And in the cardiac realm, we have had data on wait times really for a very long time through Core Health and and CCM before that. And one of the advantages of that is you have data. So it is impossible to know if your wait times are not optimal if you don't have data on it and you count on having to look at individual physicians' offices. So having data on understanding what wait time volumes are, trends, and it will be unequal across the province, I think is a fundamentally good thing and one that I would certainly support. The second is, well, how do you then deal with those wait times once you have it? And I don't think there's a one size fits all. There's been a lot of work that's been done on single entry systems, whether that be at a hospital level, a practice group level, whether that be at a regional level or provincial level. I think it comes to the concept of load sharing, and there are things that you have to balance off. Patients receiving treatment closer to their home, patients receiving treatment from a physician that they are comfortable with, versus the downside of delays. And I think for each condition that's different. I am a strong supporter that we need to wrestle with each of those issues for each condition and look to see what is the best balance of those. And if the system has implicit disincentives from doing that, if there are financial incentives to work within silos, we must actively look at removing those. But I think the start of the conversation of having a program that looks at this is certainly, to my eye, a positive thing.
So my next question I have is from Julia Costanzo at CBC, and I'm going to direct this question to Dr. Goyal. Is there anything that could have been done to reduce or prevent this backlog, apart from stopping the spread of COVID-19?
Yeah, so that in itself is a complex question as well. On the surface, it seems simple, but it's not so simple. As we went through wave one, we didn't know really what to expect. We had to pivot suddenly into virtual care options to try to keep everyone safe. Our offices weren't necessarily equipped to deal with the spread at that time. So, for example, installing barriers, air purifiers, things along those lines took a bit of time. In addition, with wave one, we had a lack of PPE, and that was throughout the country. So it was difficult to see patients in person for many physicians. And then as that progressed, as we went into wave 2 and 3, especially wave 3, the burden of illness increased significantly. Especially, I practice in Peel, which was one of the hardest hit regions in Canada, if not the hardest hit region. And at one point, it was every other case, every other patient I talked to had COVID symptoms. And so, could we have done something? Well, it goes back to even pre-pandemic. When we look at some of our illnesses, such as mental health illness, we know that there is already mounting pressures on the system. There was already a backlog. Pouring more resources into that realm of things would definitely help. Would it have helped? I don't like to look back. We want to look forward, of course. Now that we've gone through COVID-19, we didn't really know how long this was going to last. Now it finally feels like there is a bit of light at the end of this tunnel. So I think definitely things could have been done in some of those realms where we were already behind. And had we fixed those ahead of time, perhaps it would have been less. But the reality is we're here now, and we have to look forward. We have to figure out innovative solutions, as Dr. Vijay Sundar said. And we have to make sure that those vulnerable populations aren't left behind, as many of them were left behind during COVID.
And as a follow-up, and I'll direct this to Dr. Landolt, how does Ontario compare to the rest of Canada in terms of this backlog?
Dr. Landolt,
I believe you might.
I would say it's probably very similar. I mean, we don't have any hard data, but just by talking to colleagues, it's very similar. Everyone has the same struggles and the same, we're all dealt with very similar cards. So I think everybody's behind.
Thank you. The next question I have is from Nicole Ireland at CBC News, and it is, Dr. Wujasindra said that inequalities will persist unless we are deliberate in this recovery phase. What are some of the tangible things that need to be done? For example, what kinds of barriers are vulnerable patients facing that they may be preventing from getting care in this recovery phase?
Sure. So I have almost no doubt that if we simply increase capacity, the patients who will recover first will be, those who are not marginalized. And if we were to use, a tangible example of that during the pandemic, the heat maps of vaccination rates versus COVID rates were inverse to each other. I think the fact that that prompted innovative solutions such as pop-up clinics to deal with that is an analogy to what are the type of specific things I think will be needed when we go through this recovery phase, that to simply increase more capacity and hope that marginalized communities will be able to see their family doctor. I'm not sure that'll work, but the pop-up clinic worked because it took it right to their community and worked with what tried to find solutions that worked within their circumstance. And I think certainly in cardiac screening, just getting people to primary care, those are the types of solutions I would look to see if they worked. So that's a kind of singular example, but I think the broad idea behind things like pop-up clinics was to look deeply within those communities that are marginalized and try to find solutions specifically for them. And as we expand out to whether it be the recovery or preventative care, cancer screening, I think we need to think deeply about what will work for those communities. We actually know what those communities are going to be. What are the communities that are going to be disadvantaged? And targeting our recovery interventions to solutions that will work with them as a theme, I think, is an important one.
Excellent, thank you. My next question I'm going to direct to Dr. Kassam, and it's from Ian Sheriff-Scoff at iPolitics. So the Financial Accountability Office of Ontario estimated that clearing the backlog of surgeries in Ontario delayed by COVID-19 will take more than 3 years and cost the province $1.3 billion, roughly $700 million more than it budgeted. Does the Ontario government need to put more resources into this?
Thanks for the question. I think resourcing is going to be part of a solution for the future. No matter how you slice it, there's going to have to be investment in the health system in order to work through not only this backlog, but everything else that comes along with it. And whether that includes the transformation of the healthcare system or reorganizing our healthcare system, that's going to be part of the solution for sure. I think the broader question perhaps to ask is, how do we restructure in a way where we're actually providing value for our patients? And in my opinion, I think that doctors have been at the forefront of not only this pandemic, but of reorganizing our healthcare system. I know Dr. Wujasindra, for example, has been instrumental in doing that at Sunnybrook Hospital, and physicians across the country, really, but certainly in Ontario, have been at the tip of the spear. And what that means is that physicians have been innovative. They have been able to do things like organize pop-up clinics, or provide healthcare through virtual offerings, or try and work through some of the challenges within the pandemic, whether that was PPE or whether that's erecting new things in their offices so they can provide care adequately and safely. Doctors have been innovative. They have been able to change very rapidly. And so that type of leadership, I think, is extremely important for the future. And I do believe that that doctors will be part of that solution for the future.
Thank you. The next question I have is from Liz Payne at the Ottawa Citizen. It is, we have seen COVID patients transferred around the province during the pandemic. Do you foresee patients continuing to be transferred for treatments in an effort to deal with the backlog? And I open it up to all of our physicians today. I wonder, maybe perhaps you could each provide a bit of a perspective from your own practice and what you're doing currently.
So I'm happy to start. I think my broad answer is that we need to be open to that possibility, that making use of the full capacity of our healthcare system across the province is a really important one. And we must be open to that possibility and making use of it for the individual patient or the individual types of patients for whom that would be of benefit. Um, I've been really deeply influenced by the fact that the IMS table and how hard they worked to load share across this province uh, really was fundamentally uh, one of one of the big innovations of the pandemic, and really was a major contributor to how we dealt with it. And it will be a lost opportunity not to build on kind of the experience gained from that, what worked, what didn't work, and apply it to other conditions where needed. I think we need to be open to that possibility and explore it.
Yeah, I totally agree with Dr. Vijay Sundara. The other thing that we see, and sometimes it's some perceived bias that we have as physicians. When you talk to patients, and depending on their medical condition, and you ask them, are you willing to travel an hour to go for an MRI, or are you willing to go, maybe a couple hours to go for a procedure? Some are capable of doing it, and again, they would jump at that opportunity to move up in terms of their procedures. But we have to realize that there are inequities here, and not every patient can travel. Not every patient has the means to be able to go even 20 minutes away, half an hour away for something. And so we have to make sure that we equal that playing field as well, if this is something that we continue to do. But there's no doubt the IMS table did create efficiencies, and we have to learn from that.
Excellent. Next, I'm going to pass a question off to Dr. Kassam, and this one is from Liz Braun at the Toronto Sun. So I have two questions for you. The first is, does the OMA intend to work with the RNAO on the backlog issue? And as a follow-up, registered nurses are leaving the profession in droves in Ontario, partly because of COVID. How can surgeries proceed with this shortage?
Thanks for the question. The OMA and doctors, I think even on this panel, would agree that healthcare is a team sport. And so our task right now, not only during the pandemic, but as we move to a future state, is to work with our health system partners, all comers, to get to a point of success for the patients of Ontario. And so that means working with other organizations. It means working with government. It means working with other stakeholders. It means reaching out to other institutions to find solutions to a lot of the problems that we're facing. And so we are excited. We are committed to actually building those bridges in order to transform the healthcare system for the future. We're seeing the same pattern even in the physician community, right? COVID has actually initiated early retirements for a lot of physicians who may have been at the tail end of their career but decided to move up their retirement because of the concern about COVID, but also in some respects the landscape of healthcare. And so health human resources is always an issue and has been an issue in this province. And our job moving forward is to find some of those innovative solutions, unlocking some of that potential to, whether it's load share, as Dr. Vijay was describing earlier, or using technology to provide service in an efficient and an effective way. That's really our task and our goal. And again, doctors have been doing this throughout the pandemic, and I think we're well positioned to continue leading that charge.
And actually, a second question I'm going to send your way, and along the same lines about what healthcare partners can be brought to the table. This one's from Ray Chan of Tsingtao. Some people said that the government should call on those foreign trained doctors to service. Is this possible?
So again, another question about health human resources and capacity for onboarding physicians. I think that's a question that talks a little bit about physicians per capita in our region, which we know in Ontario and in Canada falls behind a lot of our peer nations in other parts of the world. And so it's not, that doesn't tell the whole story, but it is part of the story that we should be cognizant of. And so as we move forward, as we're starting to work through this backlog and this deficit of care, how do we incorporate other resources to addressing it is going to be a conversation to be had. And it's one in terms of partnership and collaboration with other institutions and other organizations. So the Royal College of Physicians and Surgeons, the Canadian College of Family Practice, all of these licensing bodies that ultimately hold the responsibility for licensure need to be incorporated, including the CPSO, for example, to really address this issue.
Thank you. The next question I'm going to direct to Dr. Goyal, and it's, what is the best advice you can give to patients right now as the focus starts to shift away from COVID patients? What should they do?
Yeah, so there's a perception that my doctor may not be available. Reach out to your doctor. Don't wait. If you have a condition, if you have a mole, reach out to your doctor. We're ready. Go for your screening tests as the system is opening up. Go for that blood work that's been pending. If you're vaccine hesitant, reach out to us and we can help answer your questions if you haven't received your first dose yet. And we can hopefully alleviate some of those misconceptions that you may have. We are open. We have been open. We've been working hard. We're working over capacity to try to serve all those patients as fast as we can. But please reach out to us. We are slowly reaching out to you as well. We're starting with the most vulnerable populations. But if you reach out to us, we will call you back. Come into our offices, talk to us. We are open. We're ready to help you.
A really great message. Thank you. My next question is from Uday Rana at CBC Ottawa, and I'm going to direct this to Dr. Wujasindra. Is there any race-based data available on who is worse or most affected by the backlog?
So to my knowledge, I've not seen such data. I'll say as a general statement, although there is considerable data available, there's always a delay to getting that data. So the data that I referred to earlier in my comments are data from 6 months ago. There certainly is race-based information on data at a provincial level that's available to us. I've not seen it analyzed, nor have I had that available to me. But it certainly is an important area that as that data starts coming in for us to be able to analyze and confirm what our anecdotal concerns are with data that verifies that.
Yeah, I'd like to just add a couple comments related. And Dr. Wujasindra mentioned this earlier. If we look at the pandemic itself, so those areas with the greatest diversity, those areas with the most racial diversity were the hardest hit by the pandemic. We know if we look at those areas at the Ontario Medical Association, those areas also have less team-based care. We know with collaboration, with team-based care, we can reach out to those vulnerable populations more. So again, it's going back to that iceberg. If we can't even see what's under the water, we can't necessarily treat those patients. And so we know we don't have hard data because it's hard to measure things that don't come into our office. But we know there's definitely some race-based things that are falling behind. And so we have to make sure that we address those things and we have to address those vulnerable populations.
Absolutely. My next question is for Dr. Landolt. What are the ripple effects of waiting so long for procedures on patients and the healthcare system? What will this do to patients' mental health?
Well, to start off with, their smaller problems will become bigger problems. The longer they wait to have anything, any malignancy, et cetera, dealt with or even diagnosed, it will be a situation whereby a larger procedure will be necessary. Other treatments may be necessary. It will be a lot more, a lot higher burden on the healthcare system to deal with the burden of treating late diagnoses, as well as the the psychological burden of having a late diagnosis that could lead to greater morbidity and even mortality. So it's huge. It's a big deal. This iceberg is even having a bigger base at this point in time. We can't even imagine how bad this is going to be. I'm very, very concerned.
I can add a slightly different perspective on that answer, that when certainly patients are affected and the condition has progressed, it is incredibly anxious to be on a wait list and not sure when your procedure is going to go through. The other component to that is the impact of this on the health team, on the physicians, the nurses, the members of my team, who have spent a year telling patients, reassuring them, we know we can't treat you now, but hang in there, we'll open the system when we can. And sometimes we've been wrong, and the patients have got very sick and we haven't got to them. So those very difficult decisions that physicians have been faced with other healthcare providers have been faced with, there is a very real moral trauma that has come with that. And as we recover from this, the resources that are going to be put into increasing capacity, the resources to increase health human resources, those same type of resources have to be put in to helping providers deal with some of the very difficult decisions many of us have had to make, and how to kind of adapt to that and move on during the recovery phase. I think the impact on patients has been extremely difficult. The impacts on health teams, cannot be underemphasized.
And I think that's a great way to lead into our last question. And I'm going to direct this to all of the panelists. And this one's from Nicole Ireland at CBC News. What is your message to patients whose procedures or screenings have been delayed and are feeling helpless and anxious? What should they take away from this news today that it will take months or even years to catch up? Maybe I'll start with Dr. Wujasindra, and then we'll work our way through the rest of the panel.
So the first is, I acknowledge how hard this is, but I also would encourage all the patients out there who are waiting to not wait in isolation. That the wait time is not a static thing. Almost every day I spend time changing our cardiac wait list because patients have got sicker, who we feel is safe to push back a bit more. We do. And so, my central message to them is to engage us, that they're not alone in this, they're not isolated. Engage with us, and we'll work through a solution to their personal issue and where they are on the wait list. Kind of on a broader sense, I guess my message to patients and providers is, as difficult as this is, it also is an opportunity. In my career in healthcare and health policy, an analogy I often feel like is I feel like I'm trying to change a system while running on a train that's going at 100 miles an hour, and you're throwing stones hoping you can change policy. Because of the pandemic, we stopped the train. Like, we've stopped it, and we get to restart it in a direction with the appropriate resources and leadership into something better. And what we create will require input from physicians, from nurses, from healthcare providers, critically from patients, and we'll need government to support us. So this is a very difficult problem, but it's a very rare opportunity, and one that we should take full advantage of.
Thank you. Maybe I'll pass it off to Dr. Landolt.
Yeah, thank you. So in dermatology, we don't really have a huge wait time issue. Our big issue is backlog. So we've already cleared the top of the iceberg, but what's sitting below is the huge amount. So basically, I guess, encourage screening. Let people know that we're screening people. Don't be afraid to be referred to come in. Find more efficient ways of screening patients. Even doing mass skin screening programs would be useful, because at this point in time, People are not diagnosed, and we need to get that under control. So basically, don't be afraid to come in and just push the realization that preventative care is just as important as reactive care.
Yeah, I wanted to echo those statements and say, one thing I want to say as physicians, we understand that you're feeling anxious or helpless. To some degree, we feel the same way as well. And, the reason why this discussion is happening is because your Ontario doctors are trying to find innovative solutions. And so I want to reassure you that, as we move through this, we're working with the system to try to change the system. We're here. Our main focus is to help our patients. And we will do what it takes to make sure that we go through that backlog and support you, even if you are feeling anxious or there are issues that you're having along the way. Reach out to your physician. We're open, we're ready. It may take a little bit more time than it used to take, but as we move forward, we're going to continue to explore more solutions. And that's what this dialogue is all about.
The only thing I would add, and all of the panelists have so eloquently described just exactly what we need from our patients, but also what we need from our transformation for the future. The only last thing that I would add is that we are still sort of in this phase of vaccination for our communities, and what we really desperately need is for everyone to get fully vaccinated. By being fully vaccinated, we will hopefully then avert any future waves moving forward, which could have implications if we do unfortunately go into a wave, having to see what we've already been dealing with in terms of shutdowns of procedures and other types of care. And so getting fully vaccinated over the summer and over the coming months is going to be crucial to this recovery period of time. And I encourage all of our patients, if they do have questions or concerns, to reach out to their doctors to ask them the questions that they can then use to better inform their decisions. So with that, I wanted to thank everyone for attending today's briefing and for your thoughtful questions. I hope the session was helpful in informing some of your reporting. I look forward to watching and reading your coverage. And if there is a topic that you'd like for doctors to discuss in the future in this type of forum and setting, please send along your suggestions to media@oma.org. And thanks again for your time. Stay safe, stay healthy, and we'll see you soon. Thank you very much. And thanks to the panelists.